Okay. All right, so we're going to talk about normal right heart anatomy and size. What happens when you have acutely elevated right-sided pressures, the 5 signs of RV strain, and some clinical scenarios. I don't know if you guys know the previous, thank you, chair of emergency medicine loved doing 5 of everything. So that's where the 5 things always come from. So as you guys, as we talked about in the basic cardiac views window, this is the parasternal short axis. Some people call this the breakfast and croissant sign. Void. Or the breakfast donut and croissant sign. Yeah, something. The breakfast plate. Oh my God. The breakfast plate view with a donut and a croissant, or a bagel and a croissant. My goodness. But the point is, you have a circular left ventricle and you have a crescent-shaped RV on the side. And this is why measuring RV function is very hard, because it's a weird structure. You can't mathematically model it like a LV, which is nice and circular. Now, it's not a perfect sphere, obviously, but you can do a mathematical modeling much easier here than you can here. And so that's why we're limited when we look at RV ejection fractions, which are mostly only done on like MRIs and stuff. All right, so this is what it looks like as a normal function of a heart. So right heart over here, let me pull up my laser pointer here. And sometimes this breaks down. So this is a normal view where you have your LV, your apex is the dominant, or it takes up the majority of the apex. And you have the rule of thirds that we've already talked about, where it's 1/3 atria, 2/3 ventricle, and about if you took this as some width, about 2/3 of it are the LV and 1/3 of it is the RV. So this is what it looks like. Remember, this is the mitral annulus over here. We'll be talking a lot over here about the tricuspid valve and the tricuspid annulus. You notice, again, it's very moving very robustly up and down here. You see a good TAPSE, or ascent to the base. And you see that the proportions are maintained. So, talk about the rule of thirds. Let me skip through this. Sorry, I forgot you guys already had this. So this is the normal one. So when the right heart has the normal pressures of the right heart, obviously lower than the left heart, but when you have a pulmonary embolus, we always love PEs in emergency medicine. So when we talk about a pulmonary embolus, this is the lung. It's very very nicely graphically represented. This is your whole specialty right here, pulmonary. it's just this tube that connects the left and right heart. And so you have a blood in one of your lung things, and and so if you have less than a 30% obstruction of your total pulmonary blood flow, you really don't have any change in your pulmonary arterial pressure, and you have essentially a normal echo. And this is why I think you guys all know this, but you can't use ultrasound to rule out a pulmonary embolus because of this fact, because a small to even a moderate size PE will not cause any echocardiographic changes. However, once the PE gets bigger and blocks more of the lung or the pulmonary artery, then around somewhere between 30 to 50%, you start getting an increase in pulmonary artery pressures. And definitely greater than 50% occlusion, you start getting RV failure. And the problem is that the right heart can't create high pressures acutely. I've seen some places say it can't create anything above 40. Most people now use probably 60 as the pressure that it can't create, that can't elevate above. So if you have something, some fixed area that's pumping blood through, if it can't pump the blood through there, it's gonna fail essentially. And so this is what happens in pulmonary emboli, and of course of any type of right heart failure, but we like to think of it as acute in the emergency department. So now we're going to talk about the cycle of why a big and failing right heart causes decreased cardiac output. Because if you have a blockage of your pulmonary artery, that's going to elevate your RV pressure, and that's going to dilate your RV. And when you have a dilated RV, you're not going to forward flow as much. It's not going to be as able to squeeze. Then you also have, because there's the tricuspid leaflets aren't going to attach as well, because now you have, like, I think we've all seen when someone has a dilated cardiomyopathy, the left ventricle dilates and you have a MR, the functional MR. You essentially get the same thing with the tricuspid leaflets. The leaflets get pulled apart, and then now there's TR, so you less blood flow going forward through your heart. Then you have this ventricular interdependence, so the right heart starts bulging into the left heart and starts creating decreased left ventricular stroke volume, and so you get the sad face of decreased cardiac output. And so there's 5 things that you can find to determine elevated RV pressure. So one's going to be a large RV. We're going to talk about underfilled LV, paradoxical septal wall motion, RV apex dominant, and McConnell sign. We always love the McConnell sign. So these are going to be 5 things we're going to go through. Okay. So when the the left heart gets large, the right heart gets large. I'm sorry if I said that incorrectly. You start violating the rule of thirds, because remember the aortic outflow here, the left atrium, and the RV should be about a third. You can clearly see that this is much bigger than these areas here. And this is an eyeball. No one actually measures this, but this looks much bigger. So that is a large RV. Underfilled LV, this starts to get skinnier and those walls start to get closer together. Okay, here's the peristernal short axis view of kind of the same thing, where you have now, instead of having a nice crescent-shaped RV, now you have a circular RV or near circular, and now you have what we call the D sign, which is a flattened interventricular septum that's pushing in on the LV, creating the D sign. Some people call this the OD sign. This is the O, this is the D. One of our someone calls it the oh dear sign. I don't know, whatever sign you want to call it. But this is also, the septum is shifted over. So now you're getting the septum into the LV and you're getting that ventricular, you're seeing the effects of ventricular interdependence. And then when you jump into the apical 4-chamber view, now instead of the RV being smaller and the LV being an apex dominant, now the RV is going to be the dominant structure at the apex of the heart. And you could have McConnell's. Oh, and notice that the rule of thirds are violated here. Now, this measurement here is probably bigger than this. I should say it's definitely bigger than this measurement over here. And anytime this side is bigger than the left side, that we call that severe RV dilation. So right side bigger than the left, that's severe. And then McConnell sign, our favorite thing, is when you have decreased function of your RV over here. So your RV is not contracting as well because it's failing, but the RV apex is spared. So meaning it's hyperdynamic. And so you have a very contractile apex. And so we refer to it as a winking of the apex. Let's show you what that looks like. So again, you have hypokinesis of the free wall. If you took M mode and measured the TAPSE right here, that TAPSE would not be normal. It would be diminished. So hypokinesis of the free wall. And again, the free wall is the wall that's not the septum. And then normal contraction or sparing of the apex, and to get this apical wink. Do you guys see this winking thing over here? This little muscular structure is a moderator band. This is normal. If you look at a bunch of hearts, you'll start seeing this more often. This is a normal structure in the RV, and that's sometimes how we tell the RV from the LV. So that's fine. But our eye is sticking at this apical wink and the hypokinesis of the free wall. Makes sense. So this used to be called pathognomonic for a PE. It's not. It's probably better to say pathognomonic for an acutely elevated right-sided pressure. The only other time I've seen this personally, besides a PE, was actually scanning in the ICU with you guys. There's someone that rapidly developed ARDS and got a McConnell sign, and so got a CT scan to look for a PE, and it was normal. It wasn't normal, but it wasn't normal. There was ARDS, but there's no PE. So I forgot to mention at the beginning of this, I scan with you guys every other week in the ICU. I don't know when it starts for you guys, like that's up to Meredith, but every 2 weeks I'm up in the ICU on Mondays at 3 p.m. And so I'll be scanning with you guys. And usually we just go over whatever you guys are interested in or whatever pathology is up there. So you guys will see my face a lot more, and some of them when I can't fill it, when I'm busy or something. Okay, TAPSE. We've talked about it. We beat around the bush, but now let's talk about it. Tricuspid annular plane systolic excursion. So again, this is the tricuspid annulus. You put an M mode spike through there. You see how high this goes up and down. You measure the ascent of the base. And so this TAPSE is 28 millimeters. That is very normal. Think of it as a RV ejection fraction, or a surrogate marker for the ejection fraction. Abnormal, I don't want to bog you guys down with too many numbers, but I feel like this comes up a lot. So 1.6 is usually what most people use as the cutoff for abnormal TAPSE. So this one, they put the M mode through the tricuspid annulus, and they saw that the TAPSE is only 6 millimeters. And you also notice we switch very quickly between millimeters and centimeters all the time. That's confusing for some people, but I apologize. We do that a lot. So this is 6 millimeters, so it's under the 16 mark. So this is a severely depressed RV function. And notice that the RV is really big over here. It violates the rule of thirds. It's bigger than the LV. The right side is bigger than the left side. And look at this right atrium. Holy moly, this right atrium is bigger than the right ventricle. So this is a sad right heart. Generally, mild enlargement of the RV can be hard to see, especially if you're starting out. So it means it's enlarged and there's different criteria, but it's still smaller than the LV. Then we say moderate is when your RV is equal to your LV in size, like over here. If your RV and LV were in equal size. And then finally, severe, I mentioned this earlier, is greater. The RV is greater than the LV. Okay, we talked about dilated RV. Some people call this the RVOT, technically, right ventricular outflow tract, and this underfilled LV. Let me skip through this. We talked about the rule of thirds. Okay, this is an abnormal rule of thirds. So this is a third, this is a third, or should be a third, and then you have this thing right here that's far greater than this aortic outflow tract. So that is a big RV. Do you guys see that? Okay, here's another one just to get some reps in here. Look at that LV. You can tell it's not just cut. Sometimes you get a bad cut of the LV and you're like, oh, well, it's just off axis. You can see both of the walls very clearly of the LV. See the mitral valve nicely. You don't see the aortic valve a little bit, but you can see these walls are being smushed together. They're just getting crushed. So there is a definite underfilled LV. All right, here is the flattening of the interventricular septum. Instead of being circle, now it's a D sign. So this is normal, nice circular one. This is an abnormal one. Here's the O. You're gonna have to, we're gonna take some artistic liberties here. It's kind of an O, but it's ginormous. It's much bigger than the actual cavity of the LV, which is the tiny little thing over here. It's getting smushed. And you can see the D sign here. Here's another example. You can see very nicely this interventricular septum being squished, creating a D sign right here and a big RV. Does that all make sense? It's all well and good. All right, McConnell sign. This is just all spelling out. So this is normal here. A nice thin, or what we call a sharp RV, because it's like comes to a nice point. It's not ballooned out. It's a very nice pointy RV, as opposed to over here where it's not pointy anymore. It's kind of a ballooned out RV. And now your RV apex dominant. So the apex of the heart looks like it's being controlled by the RV. And then the TAPSE, it's not measured here, but doesn't look like it's moving as vigorously as it should. That apical wink is a little hard to tell here, because especially since the free wall is a little cut off, but there might be an apical wink there. So another sign. So this one, and again, the TAPSE is down over here. The RV is apex dominant. The RV is bigger than the LV. I don't see an apical wink here, so this is probably just a chronic RV dilation. Oh, this is a good apical wink here. So this is, again, acute RV pressure overload. Another one, just a RV is big, and the TAPSE is not as good. All right. So people always want to know, is it acute or chronic? Well, you can actually try and figure that out by measuring the RV wall thickness. I'm going to tell you this is advanced. Not a lot of people do this, but if you go into the subcostal view, so you get the liver and you get the RV as the first things in the screen, and you zoom in, there's pericardium right here. So you don't want to include pericardium, but you actually measure from the not bright spot, just the myocardium here. And if it's 5 millimeters or less, that's a normal RV wall thickness. Normal thickness is, they say paper thin, but I guess that's not thin as paper. Or chronic is greater than 5 millimeters. And this right here, you can see is a very large, this is like over a centimeter right here of an RV. So this is a chronic process. And then people always ask, how do you know you don't have a chronic, if you see a chronic RV dilation? Because at most acute RV dilations, they're going to get a PE in the emergency department, at least from our standpoint. But if it's chronic, people are like, how do you know that they don't have a chronic process and then an acute PE on top of that? Okay, well, you always, yeah, I guess you could. But so get a CT scan, I guess. I don't know what to say. There are some like really advanced ways to look at RV pressures to look for acute changes, but for the most part, you're probably gonna need a CT scan if you're concerned for a PE. All right. So this is another case of someone we had. You can tell the rule of thirds is violated here. It might not be that obvious in parasternal long, but what I want you to take away is like sometimes your brain goes, huh, that's a little weird. That's just a little weird. I'm going to keep my eye on this. This might be dilated. This might be normal, but I'm going to look at it in other views and really focus on the RV. And then all of a sudden you see the RV cavity is this big and the LV cavity is this tiny little guy right here. And you see this bowing of the interventricular septum. Usually you have a plethoric IVC. What's that? Yep. And you get your apical wink right here. Another one. Big RV, small LV. You guys got it here. All right. Probably around 30 to 50% of the pulmonary artery needs to be occluded before you have echo findings. And these are the 5 findings: large RV, underfilled LV, D sign, RV apex dominant, also known as RV kind of being blown out or rounded at the apex, and then McConnell sign. A lot of people also ask, how do you measure someone's right ventricular systolic pressure? This equation is not, it looks complicated, but it's not actually very hard. If you can get a good apical 4-chamber view, let me go back to this. And well, the tricuspid valve is not really well seen here, but if you can find the regurgitant jet from the tricuspid valve, and you actually measure the speed of the tricuspid regurgitant jet, the maximum speed, say it's abnormal at 3 meters per second, so it's very fast, 3 meters per second. You just plug it into this equation here. Oh, sorry, and you have to look at the IVC, and you plug into this equation here, and so 3 squared would be 9 times 4 is 36, and then you look at the the IVC, and you get a right atrial pressure. Oftentimes it's 15, so that'd be an RVSP of 51. So the majority of people have a TR jet, even if you don't have pathology. Not everyone though, but I want to make sure that the TR jet itself is like the brightness of the TR jet is not related to as pulmonary hypertension. Like tricuspid regurg is not related to pulmonary hypertension. They're separate. We're just looking at the tricuspid regurgitant jet, the speed of it. And so here's a little infographic. So if you had apical 4-chamber, you put the Doppler this time on the atrial side, and you have to use continuous Doppler, which I just realized now I haven't discussed. But continuous Doppler is now to measure very fast speeds, usually for pathologic valves. And say you get a gradient. So this is your tricuspid regurgitant jet. Say it's 3 meters a second. You plug that in. And then you look at the IVC, and remember, this is how cardiologists do it. They say, oh, if it's small, it's 3. If it's big, it's 15. If it's somewhere in between, it's 8 as the right atrial pressure. Like, seriously, that's actually what cardiologists do on their echo reports. You think there's something fancier than that. And so they just put these two numbers together, and you get the RVSP.